Good afternoon, everyone. I'll make sure I got this technology. Okay, good. Pleasure to see you guys. Had an opportunity to talk to you before, so always looking forward to coming back. And I do want to talk to you about COPD today, but I made a special slide for you guys this morning before I came over. So this is the AAPT program in Hickory, and in case you haven't figured this part out yet, helping to promote the best technicians ever. So that's my contribution about this. So I thought I really enjoyed Tina's presentation, and I'm familiar with nurse navigators in our cancer center hospital at UNC and the kinds of things they do, and certainly I think the kinds of care and the issues that cancer patients deal with require that kind of a specialty service, and and a lot of the medications for patients with cancer also come from specialty networks, and so I think the nurse navigators do a lot of those things as well. But I'm also thinking that if you're involved if you're working either in a health system setting or if you're working in a community pharmacy, you probably have already been impacted by changes in healthcare reimbursement and what's often referred to as value-based purchasing, which is the way that doctors' offices and hospitals are paid for patient care. And over the last 2 or 3 years, there have been numerous disease states that have been put forward in that kind of payment system, and it's called value-based purchasing, and it's really more of a focus on the quality of care and the kinds of things that happen with the patient. And it's really important to the health system and the doctor's office because they can actually lose millions of dollars if they kind of don't meet the marks. And it started with heart failure and acute myocardial infarction, a heart attack, and pneumonia, and then a little over a year ago they added COPD to that mix, and then they added some orthopedic surgeries as well. And so I'm saying that there's a new kind of service in health systems, a big focus on things called transitions of care, so to try to make sure that when patients are ready to go home, that they're prepared to go home, because the risk to the health system is if they come back, especially with those particular diseases, within 30 days, the hospital eats that cost, and they get a bad mark on the report card as well. And so there's a lot of effort now, and there are whole new programs in hospitals and health settings dealing with transitions of care to make sure the patient understands everything and they have everything that they need. And the reason I say that I think that probably impacts you in the community pharmacy, I know at UNC hospitals, we now have pharmacists or pharmacy students or pharmacy technicians making calls to community pharmacists that that if the patient is in the emergency room, that they're doing medication reconciliation, or at all hours of the day, or sometimes during the usual work day, that there's a lot more calls going from hospitals to community pharmacies saying, listen, this is what we have on this patient, is that the same thing you've got? And I've checked with, I think that it kind of puts a big burden on the health system in general, because we're already very busy. But I think the bottom line is it's all in the best interest of the patient to do those kinds of things. But I think it's been hard to handle, and I think it's also additional workload in the community pharmacy. So I want to talk about a few things related to COPD that should represent the standard of care, and I'll try to touch on some new things in terms of doing that. Let me start off with a patient case here, and this gentleman is a 66-year-old man with COPD and congestive heart failure, not an unusual combination at all. He's in the emergency room because he has symptoms of shortness of breath and an increased cough. He's coughing up sputum, and that sputum is different than what it normally looks like. He describes the fact that he has less exercise ability, less energy than he's had in the past, and he's waking up at night more with shortness of breath. And in the emergency room, he's He presents as a elderly man. It's obvious that he has this rapid respiratory rate. He's sitting upright on the table. He appears to be in distress, and his nail beds reveal cyanosis, which means that he probably has low oxygen, and he can't really even talk in full sentences because his respiratory rate is so fast. His medical record suggests that he has this diagnosis of COPD, diagnosed 12 years ago and associated with a 60-pack year smoking history. And he's had congestive heart failure, another consequence, cardiovascular disease as a consequence of cigarette smoking as well, for 8 years. And he's also had a history of hypertension, and he had a heart attack 10 years ago. He also suffers from the old man's disease, BPH, but that's pretty well controlled with tamsulosin, Flomax. I feel like I'm getting the age that I don't learn very many things new every day, but I do discover I probably do learn something new every day. But about 2 weeks ago, I was in the hospital and I saw tamsulosin on a woman's profile, and I just thought it was a mistake. But apparently that drug gets used. I've probably never seen a woman on Flomax, but it does get used if they have some bladder outlet problem. And then the gentleman also has anxiety and uses lorazepam or Ativan for that. He's self-sufficient at home, and he can get around his house and take care of the property and those sorts of things. He is a widower. He has a couple of kids, but they live pretty good distance away. He's retired, but he has good medical insurance with a Medicare Part D benefit. He continues to smoke. But he doesn't drink alcohol, and he describes his COPD as having symptoms most of the time, worse if he exerts himself, and he uses albuterol, ipratropium, or the Combivent inhaler for that, and his heart failure. Sometimes he has some swelling in his legs, but he says that sometimes that's related to his diet. So this is what his medication looks like. You can see his chronic medicines include tiotropium, Spiriva, and the Combivent inhaler, and then some other things for his heart failure and his BPH. Furthermore, in the emergency room, he's relatively afebrile. His blood pressure looks okay, and his vitals overall are pretty good, although that respiratory rate of 24 is increased. His lung exam shows things that we might expect in a patient with COPD. His cardiac exam is not changed from before. He does have trace edema in his legs, and his oxygen saturation is down a little bit. It's 88%, and his labs that are pertinent include potassium at 3.9, a modestly normal serum creatinine, and then his chest X-ray looks like, again, like a patient with COPD. So he's asked if he can cough up something for examination, and he is able to do that, but the laboratory doesn't use the specimen, which is not an uncommon thing. It's hard for a patient to produce a sputum that's acceptable to the laboratory. But because of his symptoms and because of his relatively low oxygen, he is admitted to the hospital with a COPD, with a COPD exacerbation. And so a little bit of introduction with that. I'm going to talk just very briefly about exacerbations, which is what happens in COPD patients. They have these periods of time where they get an acute worsening of their condition. Sometimes they require hospitalization, sometimes they don't. But it does require a change in their therapy. And in the last few years, we focus a lot more on exacerbations because, as you're going to see in a moment, COPD is a disease that just gets progressively worse, especially if people keep doing whatever made them have COPD to begin with, which in this case, in most cases, is cigarette smoking, so it tends to get worse and worse. The problem with an exacerbation when a patient gets acutely ill is that, the way I think about it is that, the COPD patient is usually slowly declining, but an exacerbation is almost like a full a stair step. Okay, so they're up here, then they get an exacerbation. They fall down a lot with their overall health and their lung function, and they get that exacerbation treated, and they come back, but they don't really get back to where they were before. So they're a whole stair step down, and so a lot of emphasis in chronic management now of COPD is to try to prevent those exacerbations from ever happening. And you'll see that a lot more in the drug label, even more so than we did before. And so that's the last point that's pointed out on this slide, is that exacerbations are significant events, and they hasten, they make the patient, they take a patient down an additional stair step in their disease. And the other thing just to kind of know is that exacerbation it's more like a syndrome. It's not like a pneumonia. It's not, I mean, a pneumonia, patient goes in the hospital, they get an x-ray, and there's some fuzziness and things on the x-ray, and you say, well, you have a pneumonia. You could have that with heart failure and some other things. But exacerbation is really, I mean, it's number one, it's infection in the airway, so it doesn't really necessarily change your chest x-ray. It's really, a syndrome. It's that a patient might have a fever, they cough more, their sputum looks different, they're more short of breath, they have more problems sleeping at night. So it's really a kind of a constellation of things, and we say, well, okay, we're calling this an exacerbation and making some change in treatment. As I said, we could do that in the hospital, or we could do that at home. So in this case, this gentleman's going to be in the hospital, but these goals are the same things that we would try to do if the patient was home, and that's, make them feel better, relieve their symptoms, prevent something bad from happening to him during this exacerbation, and as much as possible, get him back to his general health and prevent a hospitalization if we can, and prevent him from dying. So as I said, I want to talk just very briefly about exacerbation. So if you're working in a hospital setting, I think what we see with a COPD patient that comes in the hospital, the treatment for the exacerbation is fairly straightforward. Now remember, this gentleman has both CHF, heart failure, as well as COPD. So and he has evidence that his heart failure is not totally well controlled. So there are going to be some other things done with his heart failure, probably increased diuresis with furosemide and maybe some adjustments in his other medicine. But for the exacerbation itself, there are just some very general kinds of things that get done, again, in the hospital or at home. And they really, we're going to give oxygen if the oxygen's indicated, and for, kind of the bottom line for an acceptable oxygen, hopefully our oxygen level, our oxygen saturation in the absence of us having lung disease is hopefully 98, 99%. The lower limit that's acceptable to make sure that at least there's enough oxygen in the blood to meet the needs of the heart and the liver and the brain is about 90%. So this gentleman was at 88%. So, I don't think he's wearing oxygen at home. So this exacerbation has made his oxygen lower. So he definitely would get some oxygen in the hospital. And then, from a medication standpoint, basically we're going to take those inhalation products, albuterol and ipratropium, that are the fastest acting things that we have, and we're going to increase those. I refer to that as intensification. So likely he's going to get nebulized treatments with albuterol and ipratropium every 4 to 6 hours to try to help keep his airways open a little bit more and help mucociliary clearance, so he can clear this excess mucus and infected mucus that's in his airways. The second big thing that's very definitive is that he's going to get started on prednisone. Usually he could get methylprednisolone, but really oral prednisone is just fine, so he would get started on that at 40 to 60 milligrams a day, and usual exacerbation would have that happen for 7 to 10 days, maybe up to 2 weeks. And for the exacerbation, we're going to give him some antibiotic that's directed at the things that usually cause the exacerbation. So the medical treatment, which is shown, it works. It helps the patient recover from the exacerbation, has increased their bronchodilators, give the prednisone, and then give antibiotics. Now, one thing that you might, again, if you work in the hospital setting, one thing you might see more and more in orders and things like that is there is something called non-invasive positive pressure ventilation, and that's referred to as BiPAP. And so that's actually just a machine. You know, people at home that have obstructive sleep apnea use a CPAP machine. A BiPAP machine is like a CPAP machine. It's just a little more, it's just fancier and a little more aggressive therapy. But this kind of therapy is increasingly important in hospitalized patients that are having respiratory problems. And the reason it's important is that, you know, if you're in the hospital and you're having respiratory problems leading to respiratory failure, where you just can't perform the work of breathing anymore, you know, what's the next step is that you're going to be intubated and on a ventilator. What a BiPAP machine does is try to intervene before you get to that point. And so it's like a CPAP machine. It's a tight-fitting mask, but the patient's not, is not on a mechanical ventilation. And so it's an effort to try to, improve their lung function and their gas exchange enough so that they don't, they don't have to be in the ICU and be on a ventilator. So it gets used more and more, and and it usually has some benefit. Even though if maybe if you had a family member or something that had to use it, it's not an easy a treatment to accept. It's uncomfortable. You got a tight-fitting mask on. It can make you feel more short of breath. So a lot of patients refuse to wear it, or refuse to wear it as long as the medical people want them to. So it has a lot of good benefits, but it's clearly very hard for a patient to tolerate. So if you have questions about, hold on to that. So now in healthcare settings, what we're thinking about is how are we going to manage this patient and be able to send this patient home and be assured that they're not going to come back again, because the healthcare system, payment system is more on value and and the quality of care that the patient receives, and so there's a lot of emphasis in that. And so in treating this patient in the hospital, the things we think about is, are we giving them the right therapies in the hospital? Of course, are we not making mistakes in terms of the way that we give that care? And then a lot more attention than happened 5 or 6 years ago goes more into when we're going to send that patient home. Are they going to be successful at home? And so all of that is, it's a lot of work, but hopefully it all works out better for the patient in general. So I added a couple of slides in that talks about that a little bit. The concept is called value-based purchasing. It's the way that the healthcare system is moving to say you're going to get money when you do a good job, and if your hospital doesn't do a good job with certain kind of patients, you're going to get less money than somebody else will. And whether you know it or not, this is ultimately, this value-based purchasing kind of thing is ultimately somewhere down the road going to impact community pharmacies. There will be a time, in the next 5 or 6 years, that the reimbursement for dispensing a certain kind of medication is going to be based on what that pharmacy's report card looks like. And so that's going to be pervasive through the whole health system. And right now, again, it impacts physician offices and hospitals, and so there's a lot of attention put towards making sure that we're that we're doing the best that we can in that area. And so that is why it's important to keep this patient from coming back in the hospital. And so we have case managers, and we have nurses that have increased responsibilities, and we have the physician that has an increased responsibility, and we have pharmacists. So they're in health systems now. Most hospitals have kind of a checklist. Has the nurse done what they're supposed to do when the patient's getting ready to go home? Has the pharmacist done what they're supposed to do? And somebody's looking at all that to say, okay, is it safe to send this patient home? And that, a lot of that involves taking care of things, arranging things for the patient, but a lot of it also involves talking to the patient and saying, do you understand? And making sure the patient understands, when you came here, this is this is what your medication regimen looked like. Now that you're leaving, this is what your medication regimen is looking like, and all of that is aimed towards making sure that they go home and they don't kind of bounce back to us. So let's think about how we try to do that on a general basis in managing COPD in general, so they don't ever get to that point anyway. Because the first thing I said was that there's a lot of emphasis now on even trying to prevent exacerbations. So this is our current definition of that chronic disease, COPD, and that because we've all lived through the 70s, 80s, and 90s, and the first part of this century. If you thought about COPD 20 years ago, you might have thought about it the same way that most people did. We ignored COPD. We ignored COPD throughout the 70s, 80s, and 90s. We put a lot of attention into cancer and heart disease and reducing problems with those, and we just ignored COPD, and because people said, people that get 85% of people that have COPD got it because they smoked. We didn't do that to them; they did it to themselves. We kind of ignored it. And as a result, if you look at the numbers, you look at the increase in the number of patients with COPD, and if you look at the mortality rate from COPD, during that period of time when we were reducing mortality from heart attacks and strokes and even cancer in some cases, COPD numbers were going up, and up. So within the past 8 or 9 years, we kind of had a renewed interest in COPD and focusing on the fact that it is preventable, treatable, and that if we don't make interventions in those areas, then it's also progressive. And so we kind of have a renewed interest in the disease, and also maybe a better, a more optimistic outlook in terms of whether or not would be able to help patients. So let's think about what happens in COPD. So first of all, the good news is, so let's just talk about you. If you never smoked, and if you have smoked, then just pretend that you didn't. So so a couple of things about the lungs. The lungs are extremely forgiving organs, okay? And so when you're born, as you grow actually into about your mid-20s, your lung function increases a little bit, and you kind of, till obviously as a young adult, you have your maximum lung function. And then at about 35, you start losing a little bit of lung function every year. But it's really a small amount. After age 35, you lose a little bit. You lose about 1 to 2 tablespoons of lung function every year after age 35. And if you did the calculations on that, the good news is that you could live well past 100 and never be limited in anything you did because of shortness of breath. But if you do something and there's a lot of reserve in the lungs before you start having symptoms. But if you do something to your lungs, and that if you're exposed to different things in the environment, which of course including tobacco smoke, then you start losing lung function more rapidly. But even if you smoked as a teenager and in your 20s or 30s, in that most people who are adult smokers smoked before the age of 15, and there's a whole body of literature about that's why the cigarette companies always target younger people, because if you're not smoking by the time you're 20, you're usually not going to be a smoker. The rate of smoking is much higher if you start smoking before age 18. But if you think about patients that that have COPD, you're not seeing a lot of 35 and 40-year-old people with COPD. COPD, begins, those patients start to develop symptoms in their 50s and 60s. And that's because, again, you have to do a lot of damage to your lung before you reach the point where, you're actually symptomatic with something other than just a chronic, cigarette, a smoker's kind of cough. And so that's good, but it's also bad because then people don't, they feel like they're beating the odds, and they don't have symptoms, in their 40s, and they think they're fine, but sooner or later it catches up with them. So the lungs are pretty susceptible. to, I mean, you got to breathe, right? And you always can't, there's a lot of things that you breathe in that you can't control, you know, depending on where you are, but you could control inhaling tobacco smoke. But the lungs are susceptible because you have to breathe in order to get oxygen in. And so the lung actually has a lot of defense mechanisms that helps us clear things that we inhale from the, you know, from the air that's around us. But what happens in COPD is things that come out of burning tobacco are referred to as hydrocarbons, and what they do is they set off an inflammatory or an immune process in the lungs, and they kind of disturb the normal balance. There's a protective balance in the lungs that, you know, would help us clear bacteria and viruses and other, you know, impurities that we inhale. But the problem of this is hydrocarbons kind of tip over that balance and start making more enzymes in the lung, and then that actually attacks your normal lung tissue, and that's where you start getting the damage and you lose some of your lung function. And so this slide basically shows that in our lungs we have things that are aggressive. And so if you inhaled bacteria or if you inhaled an impurity, these things would help take care of them. But then at the same time, we have things that are protective that would shut this off. And that what happens is tobacco smoke increases these and decreases the protective ones, so we end up getting the damage. And where the damage occurs is both, it happens in the airways, though, you know, where the air is traveling through that you breathe in, so you end up with inflammation, so your airway looks just like anything else that inflamed would. It's kind of, you know, it's kind of swollen, there's extra fluid there, there's extra mucus there, and you know, and so it looks like it's not as open an airway as it normally might be. But the other thing is happening is that the actual lung tissue, the architecture, is being destroyed as well, and all of that results in some obstructed airflow. You can't move air in and out the way that you used to. And this is one of my favorite pictures about that. And so a normal adult lung has 300 million alveoli. So if you thought about your lung, if you think about your lung as like a spider web, okay, and that that the spider web is kind of up there, but then there's a bunch of little a bunch of little airways as part of that spider web, and they're all being held open by the other part of the spider web. And what's happening in those airways, that's where when you breathe in, all of those little 300 million alveoli fill up with some air, and then the oxygen moves into your blood and the carbon dioxide moves out. And the reason that airway stays open is because it's tethered at all of these different regions, 300 million different times. Well, if you have ongoing inflammation in there and things going on from tobacco smoke, well, inside the airway first, you know, that airway is not a normal, it's swollen, it's edematous, there's increased mucus, and then the other part is that the parenchymal part of your lung tissue, you're breaking all of those things that are actually holding that airway open, and so then you just have an airway that will just collapse on its own, and that's again why patients have trouble moving air in and out of the airway, and that's a big picture about what happens with COPD. So because of all those things, think about how that might affect the patient. So they have COPD, so they have this problem with moving air in and out, and that, you know, we take breathing for granted. Okay, we don't even think about breathing. Breathing is involuntary, so we don't even have to think about breathing. It just happens. We get a signal, and we breathe in. Our brain sends a signal. We breathe in, and then when our lungs fill up, exhalation is actually, we don't expend any energy when we breathe out. It's just, you know, your lungs are like a balloon, and that when you breathe in, then that balloon gets tight, and so then the air flows the other way. So we don't think about breathing, but in COPD patients, because they kind of lose that elasticity, they lose that balloon-like effect, then they start using muscles to help them breathe in, and then they start using muscles to help them breathe out. And all of a sudden, when we're not using any energy to breathe, they're using a lot of energy just to breathe. And so as a result, they don't have as much energy for other things. So in that case, they end up being short of breath. So if they're using all their energy in breathing, but they decide to walk around the neighborhood, well, they're going to get more short of breath, and that's going to be uncomfortable for them. And so they're going to do less of that walking around the neighborhood. So then they're going to become more sedentary, and they're going to sit around a lot, and then their muscles are going to get deconditioned. So it kind of feeds on itself. And of course, as I said, those exacerbations, those periods of those infectious events where they get worse, that just hastens all of that. It makes all of that worse, and that results in the patient, not feeling very good about life, not having a good outlook, and having a poor quality of life. And so that, unfortunately, it starts with the shortness of breath, but that leads to a lot of other things that make the patient, not do as well with COPD. Now, up until about 5 or 6 years ago, we talk about COPD, like any other disease, COPD is categorized as mild, moderate, or severe. Just like a lot of other diseases, we say, well, your disease is mild, you have moderate disease, you have severe disease. And up until, as I said, just a few years ago, that was always just based on the patient going in the lab and doing the breathing test, and depending on what their breathing test result was, we said, okay, you're mild and moderate severe. And I know in my career, I said, well, but not everybody that has the same spirometry seems like the disease seems to affect some people more than others, in my opinion. And so why aren't we considering other things? Well, now when we think about how it affects the patient, and further when we think about the medications we're going to give the patient, we start thinking about other things. We ask them about symptoms, and we say, oh, okay, so your lung function is 50%, but your symptoms are not that bad, or they're worse. And then the other thing we look at is how many times they actually had an exacerbation. So I think this is a much better way to say it's mild, moderate, severe, not just spirometry alone. This is what it used to be. Take the patient in the lab. I don't know if you've ever been around a spirometry lab, but it's just a machine, and respiratory therapy technicians are among the meanest people in the entire world. They're the people because they have to be, because spirometry is very effort dependent, and so the respiratory technicians are the ones that they have the patient there, and they're very nice at the beginning. They're fooling you, and then they say, okay, here's what, and they explain the procedure, and then they tell the patient, take a deep breath in, and blow, 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 and you feel like, even if your lung function is normal, you're saying, every ounce of air has come out of my lung, and they're saying, no, keep going, keep going, keep going. Because if you think, how long would you have to blow out before you think your lung is empty? Probably 2 or 3 seconds. Well, they want at least 6 or longer, and because the machine is telling them if it's still measuring some airflow. And unfortunately, this test is very technical also, and so they have to. Spirometry is a very technical driven test, and they've got to get a good result, and they have to duplicate that 3 times. And so that's there's a reason that they have to do it that way, because otherwise the machine will say unacceptable, unacceptable, and then the person does it more. So it's a hard test for somebody without lung function. So you can imagine what it might be for somebody with lung function. But with that, we can see evidence of airflow obstruction, and we see just decreases in the amount of air somebody could blow out in the first second, and that's one of the parameters now for mild, moderate, or severe COPD. But in addition to that, now we start thinking about other things. So we say, this is spirometry, this is their lung function over here, but now we say, well, we're also going to look at symptoms, something they say about symptoms, and we're going to look at how many times they had an exacerbation. And the way we measure this is how many times during the year do we have to give them prednisone and an antibiotic, and that would count for an exacerbation. And then it puts people in these categories. And so the ways that we look at their symptoms, there's a couple of big ways. This is the most simple one, and this has been around for a really long time, but the patient tells us, we say, we see their lung functions down, and we say, when do you get short of breath? And we'll say, walks slower than other people in his age group and has to stop when walking on a level, and that would give him a 2, and then something would give him a 3, and so we would put that in a category. This one is more, is ask about a few other things, but again, we're asking the patient, we're saying, tell me, how would you describe your cough on a scale of 0 to 5, how much mucus production, and so by doing that, then we get a score, and we're going to put them in one of these categories, and then we can look at how many times they have to take prednisone or albuterol, and then we put them in these groups. That helps us define severity, and I think using those 3 things is better than probably what we had before. So back to our patient, he says before he came into hospital this time, his COPD was pretty stable. His FEV1 was 66% of predicted, 66%. So as you'll see, actually, he's going to be in one of the bottom boxes based on that. He notes that he tries to exercise, but he has to take it easy, and he has to stop. So his breathlessness score is, I think his breathless score might be a 1, it might be a 2, and he's not been in the hospital for COPD. And he last time he got antibiotics and prednisone was 18 months ago. So he's actually going to be over here. So hadn't been in the hospital. It's been over a year since he's got prednisone. That puts him here. His symptoms put him in this category, and his lung function, this is still relatively good lung function, and that puts him there. And how that's important for us is that we now match what's the appropriate drug therapy for that in a patient like this. And this describes everything that we have with drug therapy that's available to us. And these are mostly all inhalers. There are a couple of oral therapies. Theophylline is here, and then Daliresp or roflumilast, that's something we probably don't see too much, is down there. So we're going to look at drug therapy, but before we do that, I think it's always good to say, well, what are we trying to do? When we're treating COPD, what is it we're trying to do? We should always know what our goals of therapy are. And so in COPD, much like asthma, what we're trying to do is help the patient not have symptoms, and we're trying to reduce their risk of, number 1, their disease getting worse, number 2, them having an acute exacerbation, dying, or having complications like worsening of some other disease, like in our patient, heart failure. And we also don't want the patient to have side effects from the things we're doing about treatment. So we certainly can't ignore the fact that there's some general, really simple things we should be doing. We're going to get into drug therapy, but the things that we know definitely work for COPD is, of course, stopping smoking and making sure the patient gets their flu vaccine every year, and for COPD patients that they get a vaccine against pneumococcal pneumonia. And in some people with COPD, the evidence suggests, I'm not going to focus on that sending them to some kind of conditioning program, that keeping them active, keeping them healthy, having them do some exercises, as well as kind of receiving support from other people with COPD, is actually beneficial for keeping them from getting worse. And then some people, if the oxygen is low all the time, would have to wear oxygen all the time. And so these are things that were the strongest evidence. If we were successful at these things, then the COPD patient would do better, and they wouldn't progress as quickly as before. And so I think I went back and added this in just to say we have to keep hammering away on the smoking, because it's very difficult to stop smoking. I think personally that's another area where we've learned a lot in the past 10 years. We used to just, holler at patients, say you've got to quit smoking, and then we get disgusted with them. I think we've learned to develop empathy and express empathy about how hard that is, and that the things like the 5 A's from the Cancer Society and other things help teach us how to try to be supportive to patient, and always try to change their mindset about have you thought lately about stopping smoking? And so, because I already showed you that there's good evidence that if they're successful at that, it's one of the best things that could happen, and that the medications that we have, whether it be a nicotine replacement product or one of the oral therapies, work and they help, and that they probably double or triple the rate of success of a person who's smoking. So. She beat the odds. Okay, she's lighting her cigarette up with her 100th birthday candle, but unfortunately, a lot of people won't be able to do that. So we do have several things that are available, and that there are a lot of programs that, at least for some of the nicotine products, that they're provided free of charge in some programs. And I basically my view about all of these products is that I feel like there's evidence that they all work. One thing that I try to teach pharmacy students is that, I think one of the value things that we bring is that we can try to figure out the best thing to help the patient. Because a lot of people have trouble with the habit itself, what they're doing, and there's some things up here that replace the habit, and there's some things that don't. I mean, just swallowing a tablet and hoping it works, or putting a patch on, is not helping the habit part. But those things do work well in some situations. All of these are just supposed to relieve, those unpleasant withdrawal symptoms. But I think we can tailor, which things we think would work best for a patient. So it's not the focus of my talk, but it's certainly something that I have to talk about. In pharmacy settings and in our healthcare settings in general, there's big emphasis on vaccines now. So, and that's part of value-based purchasing too. That our hospitals, if they don't give the patients the right vaccines, then they'll get less money in the future. And so, flu vaccine and pneumococcal vaccine is important in COPD patients without a question. And then that brings us to the drug therapy. And the reason that I focus on those smoking cessation, oxygen, vaccines, and those sorts of things is because those things can slow COPD. Right now, even though we have a lot of medicines, and we have some good medicines, right now in studies, there's no medicine that's been shown to, take this medicine and it will stop your COPD from getting worse. There's no medicine that's been proven to do that yet. And so, we continue to do research, we continue to develop new medicines, but no medicine that we give a patient, what it does is it relieves symptoms, and it can reduce exacerbations, but we haven't been able to see that next big benefit that it keeps, if you're losing, I'll use another number. If you're losing 3 ounces, what did I say before? Normally you lose 1 to 2 tablespoons of lung function every year after age 35. If you're using 3 ounces of lung function every year, which is what happens in some COPD patients, then by the time you're 55, you're going to have symptoms of COPD. And the medicines, even though they relieve symptoms and cut down on the risk of exacerbations, they don't. Right now, we haven't proven that they prevent, if you keep smoking, you're still going to lose 3 ounces of lung function every year. And so I'll look at medicines a little closer because, I'm just kind of throwing classes of medications up at you here right now, but I will give you a general orientation. Again, here was our diagram about, where our patients were. Our gentleman was over here. Well, what this says, the people with mildest form of COPD the best medicine for them to use would just be albuterol alone or Compavent. That's what this is saying, okay? Over here, this is saying, well, now they're having symptoms more frequently. They probably would be better off with tiotropium, Spiriva, or Ceravent, or something like that. And then at the top here is where you see Advair, Symbicort, and a lot of the new products that have a steroid in them. And so that's what that chart tells us about where those medicines should be thought about in terms of patients with COPD, and that does more of the same. And then this chart actually spells it out. So, and the COPD guidelines have really gotten a lot more evidence-based, I think, in the last several years. I work with pulmonologists. I don't know what you probably see different kinds of physicians you know, in areas that you practice, I have felt my whole life that pulmonologists were the least evidence-based of all. I mean, when I was, you know, I'm an old man now, but when I was younger, pulmonologists, I would say, why do you think that works? And they, you know, their answer was, because I said so. You know, just believe me, I'm right. And so, you know, so I always felt like pulmonologists were the worst at evidence, but just like everybody else, you know, they were pushed towards, you know, people saying, if you can't prove this, we aren't going to just base it on your opinion anymore. And so I think the COPD guidelines have become much more evidence-based to say, here's what we're recommending for this kind of patient, and we can tell you why we're doing that. And so I think it's good to know that there's actually evidence that, you know, supports all of those different kinds of things. So if we think about our patient now, before he went in the hospital, he was getting Spiriva, and he was using COMBIVENT at home, and so that was, it appears he was on appropriate therapy. But he did have this exacerbation now, so his treatment, you know, he might need to be advanced a little bit, but I think before, based on what he hadn't had an exacerbation in 18 months, that his therapy was probably appropriate for him. But now that he's had an exacerbation, well, that automatically bumps him up here. You see that if he had an exacerbation that put him in the hospital, that we should think about doing something else. And that my opinion in general has been for the past 10 years that we've overused. ICS means inhaled steroids, okay? If you look down here, you don't see any inhaled steroids. But if you think about all the COPD patients that your path might have crossed with over the past 10 years, you probably see a lot of them on Advair and Symbicort, you know, the two major inhalers. And I've always thought that we were overusing those therapies, that we should not have been doing that, but I understand why we did, because those were the only combinations that we had. I mean, they were convenient combinations, and they were heavily promoted by the manufacturers. But I think that too many people were probably on steroids than needed to be, and probably still are today, because the focus of COPD is still on bronchodilators. And so this slide says inhaled steroids are good for some patients, but not everybody, because the focus of COPD is on bronchodilators. And so that includes tiotropium, which is Spiriva, and also includes Ceravent, which is salmeterol, which is Ceravent, and formoterol, which is Foradil. But you probably don't see a lot of people use those. But I do want to. I just want to spend just a moment and show you just talk briefly about those. So those are the first-line therapies for patients. Our patients on tiotropium, Spiriva. So that's right. One class is not better than the other. There's no evidence, so choosing anything that's a long-acting bronchodilator is good for COPD. This slide says there's no evidence to say Spiriva is always better than Ceravent or vice versa. And these are all the agents that are now used that are in those classes. But basically, the point is there's not one that's better than others. But oh my gosh! So I don't know how many of you that have seen these yet, but in the last few years, along with this increased interest in COPD, starting maybe 2 years ago and going forward, these are all new products. And I have a slide at the very end that shows some of these different inhalers. But I would be interested, especially for those of you that are in a community pharmacy setting, if you have even seen, let's see, how about this here? Here's a Noro, Ellipta, here's I don't have that on the slide. Brio Ellipta. Anybody seen those dispensed yet? Yeah. And so there's been an explosion of medications for COPD. There have been very few medicines for asthma. That's a whole different talk, but that's because the companies are putting all their emphasis in COPD now. But oh my goodness. Look, I mean, these are all new medicines. They're mostly in the same class of what we had before. Some of these will be once a day, but we're going to have a lot more options going forward. These are all brand new. I mean, the Tudorza's been out, a little over a year, and of course, the COMBIVENT went into Respimat, but everything else is pretty much new. Spiriva is going to come out in the new inhaler instead of just being in a hand inhaler. So it's a great opportunity for clinicians and to make sure that pharmacists, number one, know that the patient's on the right medicine, and that secondly, that they know how to use them. So this is my little segue to say, when we see patients, okay, when we talk to patients, whether we're talking to them in the hospital or whether we're talking to them in the community pharmacy, this is here's what I usually call these my no-brainers, okay? These are my no-brainers for patients with asthma or COPD. When you're seeing a patient with asthma or COPD and they're getting their medicine, what things should we always be looking at? Are they using it? You know, is the refill coming on time? Secondly, because there's so many types of inhalers, do they know how to use the inhaler and are they using it correctly? And then thirdly, it doesn't really matter whether it's asthma or COPD, things that make their condition worse, are they avoiding those? In our patient, it would be, are they working on stopping smoking? And then finally, have they gotten their flu shot? Have they gotten their flu shot this year? And are they getting the pneumococcal vaccine? Okay. So I do want to say, let me just say one thing about, are these, if you got a question, if somebody said, well, what I want to know is tiotropium, is Spiriva safe? And, is Ceravent or is Forudil, are those safe drugs? And, and I think in general, I feel comfortable in telling patients, you know what, I feel like these inhaled medicines that you're using for your COPD, I feel like these are very safe therapies. I really do. I mean, you can go look at a package insert and you can see a lot of different kinds of side effects from those medicines, but generally I think people use those, and they might have some bothersome side effects, but I feel that those drugs that people are inhaling are relatively safe drugs. Nonetheless, sometimes people do studies and information like this comes out, and so I always keep this in the back of my mind. I'm saying, what's going on here? So basically, this was a study that asked that question, that tried to answer that question that I just asked. It said, well, if COPD patients take tiotropium, or if they take salmeterol, or they take formoterol, is it actually safe? Is it safe? And so this is actually what we would refer to as an observational study. An observational study is not an interventional study. It means that we can't say this drug caused this. We just look at people who are on the drugs, and in this case, whether or not they ended up going to the hospital. And so an observational study is different than an interventional study. It's basically saying, if they were on this drug, did they go to the hospital? It doesn't mean the drug made them go to the hospital. It just says, if they were on the drug, did they go to the hospital? And so when we look at studies like this, we see that if people got started on either class of these drugs, and so this is saying if a patient got started on tiotropium, Spiriva, what was their risk of of having to go to the hospital within the next year? And this would suggest that getting started on Spiriva increased your risk of going to the hospital by 18%. That you'd be 18% more likely to be hospitalized by getting started on Spiriva as if you didn't. And this says that similar things whether you got started on salmeterol or formoterol, and they said there's no difference between which one you got on, but this study, this observational study, says if you get started on one of these, your risk of being hospitalized, goes up a little bit. Now the problem, to me, the problem with an observational study is that, again, it doesn't say getting started on the medicine is the reason you went into the hospital. And my question about a study like this is, well, why would a patient get started on tiotropium to begin with, or why would they get started on salmeterol or formoterol to begin with? It's because their lung disease was getting worse. And if your lung disease was getting worse, are you more likely to go to the hospital? Well, maybe. So that's a question that I always have about a study like this. Again, the bottom line is I feel like those medicines are very safe, but when I see things like this, I always have to keep this in the back of my mind and say, we need to keep monitoring the safety of drugs like this, okay? So what can we say about long-acting bronchodilators in general? Number one, they don't make people live longer. They don't affect the natural course of the disease, but they're very good at reducing symptoms. They're very good at reducing the risk that they'd have an exacerbation, which might require hospitalization, and one class is not superior to the other within that treatment. Okay, so back to our patient, TC. Do we think that we should? Do we think we need to increase his therapy? And we probably do. Here is where he is now, but he's had a hospitalization. He's on tiotropium alone. And so does he warrant an increase in therapy? And he probably does. So I think I have, yes. So at this point in time, based on this exacerbation, we probably should think about adding one of the two, at least among the things that we generally see now. He probably would be a candidate for adding now another therapy to his regimen, either Advair or Symbicort, or now we've got the, back to the big list, or we could add one of the other therapies that are available to us now. But at discharge here, I think one of the things we would think about doing for him is adding one of those other therapies to his regimen to reduce the possibility that that he would come back in the hospital again. So as a result of that, what would we do? Well, definitely somebody needs to go talk to him at the time of discharge and say, here was your medicines before you came in the hospital, but we're making some changes. So here, I want to make sure that you understand what your medication regimen is going to be now, and that you know how to use all those different inhalers. We're going to make sure that you got your flu vaccine. We're going to make sure that you're up to date on your pneumococcal vaccine, that you know how to use a new inhaler, because the new inhaler he's getting is different than the old inhaler. And of course we're going to say, let me ask you again about that smoking. You're still smoking one half to one pack a day. So, and I would advise you that it would be very helpful for your lung disease if you could stop smoking, would you be willing to consider that? And so it's always worth the 20 seconds that it takes to kind of give the patient that message. And then one time it's going to click. Like maybe this time he's saying, you know what, I'm glad you asked me that, because I don't really like being in a hospital like this, and this was pretty scary. So maybe this is the teachable moment for him. So maybe that's the right time to make that intervention for him. I made this picture this morning just to show you that we can't discount the need that we have to make sure the patient understands these different inhalers. I mean, it must look foreign to them, right? And some of these are those new products that are, that are kind of inserted into the things we had before. We can't assume that patients using this is going to know how to use that. It's different inhalation technique. It's different technology, and that I think, again, it doesn't take a lot of time, but it's one thing now with transitions of cares that we're doing in the hospital setting, where we're spending more time talking about these specific things. So what we're going to do for TC is make sure that he understands each of those, that he understands, hey, we're making a change in your therapy, we're adding something else, and we can't ignore the more simple things. But somebody has to address the fact that how did he have it, what does he have access problems with his medical care. It kind of goes back to the nurse navigator thing that you heard about earlier, is that if he has problems getting health care, these days the healthcare system is actually stepping up and paying more attention to that. Because if he has a failure, then it's a failure of the healthcare system. And so there's a lot more attention going into that right now. So, and then I'll end with my no-brainers about every time a pharmacist sees a patient, I hope these are the things that they do for the patient with COPD. And what we're seeing more and more now is this kind of thing, where there's more communication going from the hospital pharmacist to the community pharmacist, or to the pharmacist in the clinic, to make sure that that patient actually has a smooth transition when they go home. And there's some evidence to support that. So I tried to do all that and gave you 2 minutes to ask me a question, or tell me something, teach me about something that I've missed that you think is important as well.
Maybe you mentioned it, and I failed to hear the report. But you were talking about the inhalers. With the addition of the inhalers, they had an increased risk of hospitalization during the observational study.
Uh-huh.
How come?
Well, see, I'm saying, it's an observational study, so all it shows is an association. When I see a study like that, I always wonder, it's saying, what they looked at is they looked at the time period between starting those medicines, because there's always been background noises. Are they really safe? And I feel like they are. But in that kind of study, what I'm saying is the fact that the patient started a long-acting inhaler had to be because their overall condition was worse. And so could it be the condition, that predicted that they were going to be in the hospital and not, not the drug therapy? That's kind of my take on it. Yes, ma'am.
This is kind of pre-COPD, but for someone who smoked for years, like 25 plus years, and they quit, they say, and the American Lung Association says, if you stop, after this period of time, this happens. After this period of time, this happens. After this, how much do you decrease your risk of COPD after a period of time of quitting?
Sure. So if you did damage to your lungs, then you have this accelerated loss of lung function. If and that's dependent on how long you smoked. And so your lung function, if you stopped smoking when your lung function was 68% of what it should be, then you're there. And that stopping smoking, it's not going to appreciably go up. It might go up, a percentage point or two. It might get up to 70%, but you basically lost that lung function. What you're asking about is that over a relatively short period of time, over about 3 years, your continued rate of loss of lung function. So most people are losing 1 to 2 tablespoons a year. A smoker could be losing 3 ounces a year. Over 2 to 3 years, the rate of loss, if you're a smoker losing 3 ounces a year, 3 years later, your rate of loss would have gone back to a non-smoker. So you go down, and so you've bought 15, 20 years of not having COPD.
You've already done the damage you've done,
right?
But you're not continuing.
Right. It's not, and your rate of loss would drop back to a non-smoker. That's why it's beneficial.
Okay.
Good question.
What's the difference in COPD and pulmonary fibrosis? Is it? I know it's not one and the same, but
yeah, no, they are different. I mean, I think it's confusing because COPD there's some scarring that happens in COPD, but that's really in the airway. Pulmonary fibrosis is a terrible disease, even though there are new therapies that are coming out. COPD and asthma, so COPD meaning chronic bronchitis and emphysema, as well as asthma, it affects the airways, what the air is flowing through. Pulmonary fibrosis is not an obstructive lung disease, it's a restrictive lung disease, and it means your lung tissue turns into a scar. Your airways might be fine, but basically it's like any other, you think about a part of your body that scars your lungs, the tissue turns into a scar, and so it shrinks up. It's like a heavy, small lung. And until recently, and it happens from certain exposures, certain toxin exposures, and it happens with some cancer chemotherapies. And it's been a terrible disease because really we have nothing to do to help patients with, but there's some new therapies coming out. But I would think of it's affecting the lung tissue and it's making the lung a big scar.
so it's not hereditary.
I don't think so. But whenever we call something idiopathic, that means we have no idea. People get, the IPF is idiopathic pulmonary fibrosis, so whether there's a hereditary component, I'm not aware that that's something that we worry about. Okay? Well, I'm going to let you guys stay on schedule. I hope you found that, I try to keep it exciting. I know there's a lot of information quickly, but hopefully it was enjoyable and good to see you guys again.